Good day. I am Dr. Mitch Taladua. I'm an infectious disease fellow, and in behalf of our AMS clinician, Dr. Maria Tarsilagler, I am here to discuss antimicrobial stewardship in Makati Medical Center as part of the culture of care in our institution. So treating infections of either pan-resistant or nearly pan-resistant gram-negative microorganisms is an increasingly common challenge in many hospitals. So here we have seen that there's a reverse development of new antibiotics versus the resistant bacteria. So this timeline here shows the timeline of the development of antibiotics and the development of resistant bacteria from 1985 to 2016. So as you can see, there is an increasing resistance or an increasing number of resistant bacteria from 1985. But at the same time, there's a decrease in the development of new antibiotics up to 2016. So this is a very big problem because we already have a rise of these very resistant organisms, and yet we don't have new antibiotics that can fight these bacteria. So between 20 to 50% of the antibiotic prescriptions are either unnecessary or inappropriate. So what do you mean by being unnecessary or inappropriate? When that antibiotic is given, even if it is not needed. So for example, even a simple cough and cold, some would take antibiotics just for that, even if it's just a viral form of infection and not necessarily an infection that needs antibiotic. Or the wrong antibiotics chosen to treat an infection. And sometimes they continue these antibiotics longer than what is necessary. Most of the time we see this, they give the antibiotic at the wrong dose. And some diseases or infections are being treated with very broad spectrum agents, when in fact these bacteria can be treated with antibiotics that are better or that is more targeted to these bacteria. So what is antimicrobial resistance, or AMR? It is the ability of a microorganism, like for example your bacteria, a virus, some parasites. It is the ability of that organism to stop the antibiotic from working against it. So as a result, the usual treatments that we give, it becomes ineffective. And so infections, they persist and they may spread to others. So why is this a global concern? Why is this not just a concern in our local hospitals? So there are already new resistance mechanisms spreading globally, and these are already emerging and they threaten the ability for us to treat the common infections. And this results in prolonged illness, disability, and death. So this becomes a challenge for all of us to control these infectious diseases. It also jeopardizes the progress and health outcomes by increasing morbidity and mortality because these patients stay longer in the hospitals and they need to be treated in intensive care units, it imposes huge costs on societies as well. So this is a partnership between the antimicrobial stewardship and the infection prevention and control programs so that we can minimize the multi-drug resistant organisms being transmitted to patients and even to the communities. So the antimicrobial stewardship will monitor any misuse or overuse of these antibiotics. And the infection prevention control unit will also check and monitor any poor compliance to any healthcare worker in the hospital. and if there's any failure to isolate these type of infections, and if there's any inadequacy in the environmental cleaning. So when a patient gets admitted, and if these things are not done properly, the patient, the longer he stays in the hospital, acquires this multi-drug resistant organisms, and thus cause your infection, increased morbidity or mortality, increased hospitalization days, and healthcare costs. And also, it can result to death. So currently, we are already in the JCI sixth edition, and the JCI medication management and use, or MMU standard, states that the hospital must develop and implement a stewardship program. So this is what we have been doing, and it introduces a new standard that identifies the requirement for organizations to develop and implement a program for antibiotic stewardship. So your measurable elements from 1 through 5 requires that a program should involve all staff and includes all patients and families. So inclusion of all staff, so that is why we are having this orientation or lecture. And then a program that is based on scientific evidence, a proper use of prophylactic antibiotics, which we will be discussing later on, an oversight of the program, and monitoring of the effectiveness of the program. So the DOH National Antimicrobial Stewardship Program mandates all healthcare facilities to implement an effective AMS program in their respective hospitals as a licensing renewal requirement. So for each level of a healthcare facility, there is a targeted timeline of implementation as shown in slide. So Makati Medical Center is a level 3 hospital healthcare facility. So we were able to target this by 2018. The DOH AMS is founded on 6 core elements. So since this is the manual of the procedures of the DOH, we need to adapt our local program as well. Thus, the MMC's AMS program has 6 core elements, namely leadership, policies, guidelines, and pathways, surveillance, antimicrobial usage and antimicrobial resistance, action, education, performance evaluation. So each of these core elements will be discussed in the succeeding slides. So what is antimicrobial stewardship? It is the optimal selection, dosage, and duration of antimicrobial treatment that results in the best clinical outcome for the treatment or prevention of infection, with minimal toxicity to the patient and minimal impact on subsequent resistance. So let's start with the first core element, which is leadership. So in 2017, with the support of the hospital administration, an AMS stewardship committee and team were created who are responsible in implementing these policies and performing and monitoring these antibiotics. It reflects a holistic and coordinated approach and aims to establish and sustain an effective hospital-wide mechanism of promoting judicious antimicrobial use in the hospital, thereby preventing further emergence and spread of antimicrobial resistance. So the overall accountability for the hospital's antimicrobial stewardship program lies with the hospital administration, which is responsible for ensuring that an AMS program is developed and implemented and outcomes are evaluated. The program is led by an AMS committee that works with the Infection Control Committee, or ICC, and the Therapeutics and Medication Safety Committee to enable a holistic and coordinated approach in implementing AMS strategies. A dedicated AMS team composed of your AMS clinician, AMS officer, a clinical pharmacist, and admin staff, together with your pharmacy services and microbiology laboratory unit, ensures that there is surveillance and monitoring of all the antimicrobials that we are using right now. So the next core element is policies, guidelines, and pathways. So these are the hospital policies and procedure manual that we have right now. And these are the related policies and guidelines that we have in AMS. So we have use of forms such as pre-authorization and restriction of antimicrobials. We audit all the monitored antimicrobials. There is a 7th-day automatic stop for all antibiotics and a 24-hour automatic stop for any surgical antibiotic prophylaxis. And these antibiotics are given prior to a procedure. So for example, if a patient undergoes appendectomy, the surgery clinician usually gives an antibiotic prior to that procedure. These point-of-care interventions will be discussed later, as well as the susceptibility monitoring, the prescription and documentation and dispensing of these medications, and the antibiotic guidelines that we have adopted. So there, we instituted barriers to prescribe and administer these antimicrobials. So we use forms for extension, and if there is a need for extension, the service or the clinician or the physician who prescribed the antibiotic will have to call the infectious disease or the AMS fellow for approval of the extension of these antibiotics. For antibiotics that are restricted in category 2, there is an automatic referral to an infectious disease consultant or to the service. So we've instituted these barriers, a 7th-day auto stop for all antibiotics. And then we also monitor and accomplish forms for extension for all antibiotics and for all surgical antibiotic prophylaxis. We also have, or the physician, requesting physician also have to fill out request forms for monitored antimicrobials and for restricted antimicrobials. And we are instituting a switch of an antibiotic from the intravenous route, IV, to a per orum, such as your tablets, if the patient meets the criteria for switching this antibiotic. So the next core element is surveillance on antimicrobial usage and antimicrobial restricted restrictions. So antimicrobial resistance, or AMR, and your antimicrobial use, AMU, surveillance provides a critical information on antimicrobial prescribing or the usage patterns within the hospital for any and or specific patient groups. So AMR surveillance monitors resistance patterns and the antimicrobial susceptibility here in Makati Medical Center. So our laboratory, in coordination with Medilink's laboratory, is an ARSP, or Antimicrobial Resistance Surveillance Program accredited. So we've had these accreditations renewal every 3 years, and just recently, last July 2019, we were again granted an accreditation for our laboratory. The next core element is education. Core element is action. So action, we already mentioned the forms that the physician must accomplish, including the automatic stop dates, the 7th day and the 24th automatic stop day. Now we proceed to the point of care interventions, such as your dose optimization, streamlining or de-escalation of your antibiotics, and switching your intravenous antibiotics to an oral form. So first action is pre-authorization and restriction. We have two categories of restricted and antimicrobials. The first includes your broad-spectrum antibiotics, including your monobactams, your 4th generation cephalosporins, and vancomycin. The category 2, which includes your other broad-spectrum antibiotics, such as your ceftolozane, and specific for gram-positive bacteria, your linezolid, and other broad-spectrum antibiotics such as your polymyxin B, teicoplanin. With your antifungals, except for fluconazole, these antibiotics and antifungals needs to have a complete referral to the infectious disease service. So these are the forms, and this is downloadable in SharePoint. So these are the forms that the physician who ordered for the antibiotic must accomplish. So there are certain information that the physician or the resident must accomplish before the AMS clinician will be able to approve these restricted antibiotics. So all monitored antimicrobials at present is already being configured in EMR. So later on, it will be an online approval. So in EMR, you can see, the physician can see these request forms already. And so there will be an online monitoring already, less of the paper forms in monitoring these antimicrobials. So as I mentioned, there will be a 7th day auto stop for all antibiotics, and this has been enforced. So if there is a need for these antibiotics to be extended, the prescribing physician must call or seek an approval, and this must be documented by accomplishing this request for extended therapy form, or what we call SDAS. So again, they will have to accomplish the indication for the extension of the antibiotic, and they will have to put in the clinical justification as well as the duration of the antibiotic. And then the AMS clinician or the infectious disease fellow who is assigned for the antimicrobial stewardship will be the one to decide if this antibiotic has been approved for extension or has been disapproved. Again, we have an automatic stop for surgical antibiotic prophylaxis. So an antibiotic is usually given as a single dose within 60 minutes prior to the surgery or prior to anesthesia induction, and this must be stopped within 24 hours. For vancomycin, this can be given 2 hours prior to surgery. So the prescriber or the prescribing physician must again put in the indication, the dose and the route of administration, and the intended duration for the antibiotic. So all of these surgical antibiotic prophylaxis may be dispensed within 24 hours, after which there's an automatic stop being enforced. If the prescriber requests that the surgical antibiotic prophylaxis be extended beyond 24 hours, then they have to accomplish this SAP form and seek approval from the AMS clinician or the ID fellow. Only approved succeeding doses will be dispensed by the pharmacy services. So it is crucial that the timing of the antibiotic for all surgical antibiotic prophylaxis be given 60 minutes before the surgical incision. And as agreed on the previous meetings, surgical antibiotic prophylaxis can be given as well upon induction of anesthesia. So there's no added benefit obtained actually from multiple doses after a single dose of an antibiotic prophylaxis for such procedures. One dose of that antimicrobial prophylaxis is already sufficient. The next point of care is to streamline or de-escalate the therapy or the antimicrobial that we are giving. So for this one, we want to streamline all our antibiotics once we already have the culture results. So we adjust the initial antibiotic, the empiric antimicrobial regimen that we started, to become more targeted and to become more culture-based. And then we discontinue any empiric antimicrobial therapy when investigations fail to demonstrate that there is an infection. If, for example, the clinician or the infectious disease service sees that there is no longer a need for the antibiotic to be continued because there is no infection, then we tend to discontinue these antibiotics. And we also discontinue antibiotics that are already redundant. We try to optimize the dosing of our antibiotics by adjusting based on pharmacokinetic and pharmacodynamic characteristics of the drug. So for example, you have a patient who has kidney disease, then we adjust the antibiotic based on their creatinine clearance. The pharmacist needs to review the following. If the prescriber or the prescribing physician is able to put in the right drug, the dose, the frequency, the route of administration, the therapeutic duplication, any allergies and sensitivities, drug-drug interactions, food-drug interactions, off-label use of the medication, or drug disease indications and other contraindications. It is required that the indication for use is included. An example, if it's for a SAP or for another kind of infection such as UTI. So switching from intravenous to an oral form of your antibiotic can be assessed. The only time that we will give prolonged IV antibiotics is if there's a deep-seated infection, if there's staph bacteremia, meningitis, septic arthritis, osteomyelitis, endocarditis, nephritis, and soft tissue infections. We have an infected implant or prosthesis, and febrile neutropenia. So these are quality indicators for antibiotic prescription and documentation. During the first R, antibiotics should be given immediately if there is sepsis. So this is part of another guideline, which is the sepsis bundle. And if the patient is not septic, and a culture can be obtained first before we administer the antibiotic. We do the necessary cultures and we write the indication and duration upon ordering of the antibiotics. If there's no indication of the antibiotic, then there's no dispensation of that antibiotic. Within 24 hours, if it's a surgical antibiotic prophylaxis, there's an auto stop. And within 48 to 72 hours, there's a reassessment of the antibiotics. It is here at this point where we will be able to get the culture results, and if we are able to get our markers, biomarkers such as your procalcitonin. We document and we reassess as necessary, or if there's a need to de-escalate any of the antibiotics. On the 7th day, there's an auto stop of all antibiotics, and if there's a need to extend these antibiotics, then there must be a documented plan. So not all culture results should be treated with antibiotics. Each clinician should differentiate the growths reported if either the cause is really infection, or if it is just the culture result is just a contamination, or if the bacteria is just a colonization. So infection is the true positive from the causative organisms, while contamination it's a false positive due to contaminants. So we usually see here most institutions have contamination rates of ranging from 3% per blood culture. It follows that if, for example, in a patient who had a blood culture done, if one of the culture is positive for a certain organism that is most commonly known as a contaminant, then we don't treat it. But if, for example, two of the bottles of the blood culture has become positive, even if that organism looks like a contaminant, but if patient is having all signs of infection, then we treat it. Colonization is a false positive due to pathogens that naturally occur at a specific site. So, for example, we do have a lot of bacteria in our mouth. So we review the laboratory results, we check if there is really a sign of infection. So we check and consider the patient's presentation as well. So what is the importance of having cultures before we institute the antibiotics? It helps us improve the chances of identifying the offending microorganism. And if we administer the antimicrobials before we are able to get the cultures, the culture yields will be decreased, and so it will be more difficult for us to de-escalate the therapy if we don't have any culture results. However, if the patient has all signs of organ failure and sepsis, then we don't delay the instituting the antimicrobial. So here in Makati Medical Center, we already have a lot of rapid diagnostics, and it helps us identify organisms quickly, and it decreases the diagnostic uncertainty. So we already have a lot of multiple rapid diagnostics. We have the multiplex PCR for bacterial and viral. We also have MALDI-TOF, which stands for Matrix Assisted Laser Desorption Ionization Time of Flight Spectrometer. And we have urinary antigens for Legionella and Streptococcus pneumoniae. So in summary, what are the actions that AMS has been instituting? First, we start smart. Do not start antimicrobial if there's no evidence of infection. So you take a thorough drug allergy history. You give prompt, effective antibiotic within 1 hour of diagnosis in patients with severe sepsis or life-threatening infections. We comply with local antimicrobial prescribing. We document clinical indications, the dose and the route of the drug. We include review and stop dates or duration of these medications. We obtain culture prior to commencing therapy. Next is to focus after starting SMART. So you review regarding the antibiotics, and if there is a decision within 48 to 72 hours to either stop the medications, to shift the intravenous route to an oral form, to change the antimicrobial, or to just continue the present antibiotic. All of these needs to be documented, and there should be a next step decision and a review for the stop dates. So here we have our fifth core element, which is education. So it aims to teach all health professionals the necessary principles of judicious prescribing and use of antimicrobials. So this is what we are doing right now, the PSSE, which is a Patient Safety Skills Essentials in Basic Infection. So we have roadshows, lectures, and orientations regarding antimicrobial stewardship. We also put up posters and exhibits, give brochures and leaflets for all patients in residence. So only use antibiotics when prescribed by a certified health professional, and never demand antibiotics if the healthcare worker says it is not needed. Always follow the healthcare worker's advice when using antibiotics, and please complete antibiotics once prescribed. Never share or use your leftover antibiotics. Educate the patients and their families about antibiotic use and preventing infections. If there's no infection, then there's no need for antibiotic use. Remember to do hand hygiene, keep your hands clean, keep wounds clean, observe personal and environmental hygiene, cover your cough, please follow the right respiratory etiquette, you stay home when you're sick, and you avoid contact with sick people, you get the recommended vaccines such as your flu shots, and prepare your food hygienically. The next core element, the last one, is the performance evaluation. So this is crucial in guiding the progressive implementation of the program, and we do have an annual AMS program monitoring report which tracks all of our progress. Measuring process and clinical indicators to assess the overall quality management improvement and effectiveness of AMS interventions is fundamental in guiding the progressive implementation of the program towards achieving the goal to combat AMR. So in 2018, we saw a decrease in the defined daily dose per 1,000 patient days for commonly used antimicrobials for surgical antibiotic. And in 2019, we see also almost 100% approval of requested restricted antibiotics. So our program objective is to reach 100% of prescribed, monitored, and restricted antimicrobials as appropriate for clinical. The same way with all our audited monitored antibiotics last 2000. For this one, we have at least a 99.4% approval for extension beyond 7 days. So all those antibiotics that were extended for 7 days were appropriately monitored. So we actually reached our goal of 95% antimicrobial use. That is stopped automatically on the 7th day unless there are appropriate indications for. So for this one, in January to December 2018, we were able to meet our compliance for surgical antibiotic prophylaxis discontinuance. So our compliance actually increased in 2000. So our compliance in 2019 was at around 85.5%. Our goal is to meet at least 90% of the operations being monitored, such that we can have the right antimicrobial choice for the surgical antibiotic prophylaxis and the discontinuation of these antibiotics 24 hours after surgery. For the outcome measures, each ward within the hospital is being surveyed 1 day only on antimicrobial prescribing and resistance, and this is done by global PPS results, by global PPS, or Global Point Prevalence Survey of Antimicrobial Consumption and Resistance. So this is the hospital ID of Makati Medical Center, and we are known as a tertiary hospital. So from 2017 to 2018, we see a decrease in antimicrobial prevalence. So before we had a 62.8 antimicrobial prevalence compared to the Philippines worldwide, nationwide, it's 57.2. But in 2018, our antimicrobial prevalence was even less compared to that of the nationwide antimicrobial prevalence. We were at 42.4 in 2008. So this is just the GPS for consumption. So here in Makati Medical Center, our prevalence, antimicrobial prevalence by region from 2017 to 2019 decreased, as I mentioned before. So from 62.8 in 2017, last year in the third quarter, we were at 45. Better than the nationwide overall antimicrobial prevalence. And actually, from 2017 to 2019, for our surgical antibiotic prophylaxis, from an 83% more than 1 day administration of antibiotics, we were able to achieve a 5% extension, more than 24 hours of these antibiotics. So we are actually already very compliant with our surgical antibiotic prophylaxis here in Makati. So these are our references. You can check this out. So remember, if all of us have a role in antimicrobial stewardship, so if we don't do any action today, there will be no cure for tomorrow. So we have to combat these drug-resistant antibiotics by being responsible in administering our antibiotics. Thank you.